Literally, this note is in front of me on my screen. It says start recording. Okay. Oh, too far. Okay. The next one, this is ascites, and here we have the tip of the liver. Here we have a kidney here. Notice, by the way, the fluid's not behind the kidney. It can't be. Not to say that fluid can't build up behind the kidney, but then it has to be a retroperitoneal process for fluid to be back here. Fluid cannot cross from the peritoneum and to surround the kidney, but it can go over the kidney because this is the peritoneal layer right there. Some intestines there as well. And this fluid space extends up to here. There's a little bit of reverb artifact, so it's... But in any case, you could see all in here, there is stuff like just kind of hanging out dependently. Looks like there's more stuff down here than there is up here, more material. That's because they're laying on their back, and whatever this is a little bit denser than the fluid, so it's down there. That is considered exudative. This person, in fact, has hemoperitoneum, and this is actually really bad. I've never seen this bad. This is actually a ruptured ectopic pregnancy. So the pregnancy was outside of the uterus. It ruptured and bleeding pretty badly. By the way, I've had patients go from speaking to me clearly to almost dead within a matter of a couple of minutes. It doesn't take long. Topics are serious stuff. Okay, so so that's exudative. Oh, and so that has a higher protein. In this case, the protein is seen as red blood cells and blood contents. That could be renal failure, ischemic bowel, peritonitis, cancer, and trauma or blood. And so, let's write that down actually. Oh, I did write it down, but let's write it a little more clearly. Hemoperitoneum in this case. Okay. Yes, this is a good one. I already wrote it down, Morrison's pouch. So once again, the kidney is not surrounded with fluid because it is retroperitoneal, but this is a pouch or a area that we look at. Actually, and we look at it for people with, or women with ectopics or suspected ectopics. Because what happens is the fluid runs along the paracolic gutters. And I didn't discuss that last time. I meant to, but I have a picture. Yes, I have a picture for that as well. The paracolic gutters. So, basically, you can't see it down there, but our uterus is down in that direction. Head, of course, is this direction. And when ectopic ruptures, fluid can run up into Morrison's pouch. Okay, where are we going next? Ah, yes, this is a cool one as well. So I said that, why did I do that? I said that we don't often look at Crohn's disease. I'm sorry, intestinal issues. It's not ultrasound's not considered the best modality for looking at intestines, but we do sometimes. And this is a great example. This is a very thick, very thick wall, way too thick. And not only is it thick, but it actually seems to be broken, and there is a growth coming out, or at least what appears to be a growth. This is an abscess. Notice also the fat in the area is echogenic. This is inflammatory fat.
A quick question.
Yes.
Is it because the fat is already inflamed that you're not really getting the posterior enhancement that you normally would get that's related with abscesses?
An abscess doesn't always have posterior enhancement. It often does because it is mostly fluid. That's a good, that's a good question in this case. Why wouldn't we see a little more posterior enhancement? It might very well be the echogenicity of the fat is a little high, but that's a good question. They don't always follow the rules, but good question. Ah, yes, I like this one. I was talking the other day how there are lymph nodes all around the aorta, well above the aorta. Now, these guys are obvious to see. Um, you can't help but see these, but sometimes they blend in to the fat in the area quite well, and then you can't see them. But this is lifted a little bit high, not terribly high, but definitely a little higher than expected. So with this lifting and then the obvious lymph nodes underneath, you can see that. These last two are kind of off topic, but they're I thought good to look at. That's lymphadenopathy. Lymphadenopathy. In fact, let me. I thought I had notes on that. Okay. So lymphadenopathy. What else do we have here? I'll open up that one too, so you can't see it. And that one. Oh, get rid of that one for a second. Okay. This one is also, I guess, slightly off topic. I threw this in. It's just simply a transverse liver image. And I want you to see, and this is once again, because so we're right after this, we're going to go into liver anatomy. And I guess I probably could have put this on another screen, but I didn't. So this is all, well, that's right lobe of the liver here. That's all right lobe of the liver. So right lobe liver, and this is left lobe liver. Notice how, and these are hepatic veins. Very difficult to talk about liver without also getting into our other class, which is vascular. But this is the middle, and both branches of this are the right and the left is not seen in this picture. And I just want you to notice how this one's kind of going off in that direction from a little lower in the screen to higher in the screen, and then this one's going off like that. And actually, I could also tell you that this over here is the heart. And so if you start to think about this, this is a bit of an unusual, like I don't know how well everyone is understanding the confusion, how this could be confusing. The heart is here, the veins are going off in this direction, or at least they're coming in from that direction. There's not actually a whole lot else I could say on this. This was actually poor planning on my part. I really should have put this somewhere else, but still, just keep this image in mind in a few minutes. Okay, just a couple more pictures, and then I also have some drawings I want to share with you. Right, the paracolic gutters. Paracolic, so para, like next to colon, next to the colon gutters. These on either side are the paracolic gutters. And obviously, if you think about it, if you're laying on your back and you have a limited amount of fluid, where is that fluid going to develop? In the paracolic gutters first, before it goes up higher. So those are the paracolic gutters. And basically, let's see, we're going to zoom out a little bit. Oh, no, it's right there. Good. I think I did that on purpose. When I mentioned with a ectopic pregnancy, we look at Morrison's pouch. This is why. Because if you follow this all the way down to the pelvis, this is the lowest part of the body, all the way down to the when a person's laying on their back, this is the lowest part of their body, all the way down to the pelvis. So if you have an ectopic pregnancy that is bleeding, the blood is going to travel in this gutter, and on the right side, it's going to come up to here. And so this is during a suspected ectopic pregnancy. Even though we're doing a pelvic, we do take 1 or 2 abdomen images just to show Morrison's pouch. Okay. I know it feels like I'm a little bit all over the place today, but there are things that we kind of have to cover. Oh, and in this picture, this is just a cool picture. I was trying to get more of them, but you had to pay for it. I never paid for it. So, well, we got a lot of things going on here. You see the linea alba there, but that's not what we're talking about right now. I want to mention of course, I'm the wrong color. Let's use green. The posterior peritoneum is going to go over that vessel, so that IVC is retroperitoneal. I guess the right kidney is retroperitoneal. This is the pancreas here. that is retroperitoneal. This aorta, retroperitoneal. Whoops. And then all the way down. And here it gets a little confusing because there's the peritoneum extends this way so that the kidney here is retroperitoneal, but the spleen, never mind, the spleen is intraperitoneal. The tail of this pancreas comes into the hilum of the spleen. The hilum, although surrounded by visceral peritoneum, the hilum has to open. And that's what I was really coming up with because I couldn't find images nor a very clear explanation why the tail of the pancreas is intraperitoneal, but the rest of it is retroperitoneal. And I thought about the anatomy is this tail has to come into the hilum. Well, the hilum is kind of the exception. We say that the spleen, the liver are intraperitoneal structures. Well, they have to have an opening. They have to have a place where that peritoneum opens up to allow blood vessels to enter. And that happens right where the tail comes in as well. And that's the only explanation that makes any sense to me, actually. That's a good picture overall. Let's see. Did I have one more? Oh, yes. This is a good one. Procedures. Procedures are simply, they're kind of mentioned in this chapter, and I figured I would show you what we help out with. This person has a massively enlarged belly. From the veins that I see on this belly, I could tell you that they probably have very likely this is liver failure. And I'll tell you why I know that, or why the veins are an indication at a later date. But this person apparently has liver failure. Someone is doing an ultrasound in order to see, well, do we have a clear shot? And under ultrasound guidance, they will stick a needle in and just let it run. And this person probably has 8 liters of fluid sitting in there. So this is a therapeutic. There's clear fluid in here, maybe a little bit of stuff down here, but pretty much pretty clear fluid. This is just a therapeutic exam, or a therapeutic paracentesis. Okay. I want to get rid of a bunch of this.
And while we're talking about the ascites, those spaces where it fills in, like obviously on all these images, they already have the fluid in there, so it's easy to make out. What do those spaces look like when you're doing an ultrasound and there's not fluid in there?
It looks like absolutely nothing. Yeah, because those spaces, we call them potential spaces. So if there's fluid, that's where it's going to go in the potential space. But yeah, we don't see it. We don't see the omentums, the mesentery, the spaces, or anything, because everything is just squished in there tight. Okay. Oh, JP, I've got a new nickname for you too. It's awesome. But let me look at pseudomyxoma peritoneum. Oh, I wanted to bring that one in. because okay, let me just go through my notes real quick. Pseudomyxoma peritone. Let me jump right back to that. I actually have an image. Yeah. Let's just pull it up. Okay. Might take a second. Oh, it's a big one. Okay. This isn't cancer, but it is potentially quite deadly. Let's see. All of this layers of really, when you're looking at this in real time, it's more easily noted. But for here, it just looks like a mess. But in real time, if you were to kind of jiggle the person's body, oh, and some people care little about HIPAA. I mean, seriously, if I were this person, no, from different countries, you can't sue. Anyway, if you were to shake this person's belly, this would actually move around like Jello. And not cancer, but this is deadly. It's usually an appendiceal or an ovarian adenoma, appendiceal rupture, spilling mucoid-producing epithelial cells. And so it acts like a cancer because these cells start growing